Okay, it looks like the clock has struck 12:15, so we're going to go ahead and get started and welcome everybody to our Clinical Conversations program. So my name is Barry Servette, and I'm the Medical Director for MCPAP, and we're really pleased to have a great speaker today for everyone and to get right into it. So as everyone knows, this is the Clinical Conversations that happens on the fourth Tuesday every month. Just for your information, the next month's topic is suicide prevention, that we've developed a new clinical algorithm, and we're going to be presenting it to you next month, and that'll be on May 28th. But for today, even more importantly, our topic is on the issue of, or the clinical topic of pediatric obsessive compulsive disorder, particularly an approach to assessment and treatment. And I am going to introduce our speaker in a moment, but just as a housekeeping issue, as usual, we have our CME credits available, and so you'll see the code on this screen. And if you're on audio only, the code is F as in Frank, A as in Apple, B as in boy, Z as in zebra, E as in eat, and F as in Frank. So we record the sessions as always, and you can get the slides on our MCPAP website under the Toolkits and Resources page. And as usual, we encourage discussion in these sessions. So please feel free to enter questions into the chat, and we will screen them and read them for you. And if you prefer to read them yourself or ask them yourself, you can unmute yourself when we call on you. Just let us know. At the end, please don't forget to fill out your survey. It'll be like a pop-up, and we really appreciate the feedback so we can address topics of your interest. So our speaker for today is Dr. Esra Guvenek-Cokol, and she is a child and adolescent psychiatrist at McLean. She is the medical director of the Child and Adolescent OCD Institute, otherwise known as OCD Institute Junior, which is a program at McLean Hospital. She's also the medical director of a program called STAR, which stands for Support, Treatment, and Resilience, also at McLean. She is a faculty member at Harvard Medical School, and has double board certification in child and adolescent psychiatry as well as general psychiatry. She specializes in emerging mental illness in teens and young adults, and particularly has an expertise in early psychosis, early onset of bipolar disorder, as well as anxiety and obsessive compulsive disorders. So thank you again, Dr. Guvenek-Cokol, Esra, for joining us, and I'm going to just go ahead and hand it over to you.
Thank you so much for the introduction, and thanks. Hi, everyone. Let me share my slides first. And can everyone see this? Yeah, okay, let's start. Perfect.
Yes.
Perfect. Hi again. So today I'm going to talk about approach to assessment and treatment of pediatric OCD. And this is just a general overview. I'll mention, we'll talk about medication treatment, but I also want to touch base on the psychotherapy approach, what kind of therapy we do, and the program I work at OCDI. So we work with teenagers 12 to 18, and these kids often struggle in the outpatient level, and we have a partial and residential level of care in our program. So it's mostly moderate to severe OCD. So I'll touch base a little bit on treatment refractory cases as well. Okay, so what do we mean by OCD? So when we say OCD, it's actually an umbrella term, obsessive compulsive and related disorders. And under OCD umbrella, we have obsessive compulsive disorder, which is the biggest one. And then the other small ones on the bottom, you guys can see, this is kind of very similar to OCD, such as hoarding disorder, which is like this strong need to save a large number of items and having a lot of distress to when you attempt to get rid of these items. Hoarding is kind of similar to OCD family. BDD is another one, but a dysmorphic disorder, which can come up a lot in adolescents, especially adolescent, and identity formation and their increased interest in the physical appearance. Body dysmorphia, BDD, in this disorder, patients believe that they look ugly or deformed. For example, they may think that they have a very repulsive nose or they have really scarred skin, but when in reality, they look completely fine. And often patients kind of seek, medical treatment to correct these deformities that do not exist. Trichotillomania is another one, which is more like a hair pulling. This is a recurrent, irresistible urge to pull hair from your scalp. It could be eyebrows or other parts of the hair in the body. And then often when the patients pull the hair, that brings this, like there's this urge to pull, and then the patients pull the hair, and then that brings relief. But then it's like a cycle, like they keep repeatedly doing this and connected with their level of anxiety. And excoriation disorder is kind of similar. It's skin picking. In this one, instead of pulling hair, patients kind of pick their own skin and often results in redness, swelling, or broken skin or infections. So like I want you guys to think that this is sort of an umbrella term, and then the most common one is what we're going to focus on today is obsessive compulsive disorder. So what is OCD? So obsessions are mostly thoughts, but not just thoughts. These are thoughts, images, or urges that are unwanted, they're intrusive, what we call ego dystonic, like patients don't like these things. It's very much distress inducing. And then these images, thoughts, urges take a significant amount of time. So it's not like fleeting intrusive thought here and there. I mean, we all have intrusive thoughts, right? But then you look at the population, like almost 80–90% of the population can report having intrusive thoughts here and there. Like it doesn't mean that you have OCD. When we talk about OCD, these intrusive thoughts, images, urges are predominantly very strong, very much preoccupying their life. And then they cause anxiety, but not just anxiety, it can cause disgust, it can cause guilt, shame. There's sometimes the patients describe this discomfort as incompleteness or uneasiness. And then in order to get rid of this feeling, patients do compulsions. And what we mean by compulsions is these behaviors, either it could be behavioral or mental acts to neutralize or undo the distress caused by obsessions. So the obsessions are connected to compulsions, and compulsions are done to make distress caused by obsessions go away. Obsessions and compulsions can be various themes that come up. These are some of the common themes that we see. For example, contamination obsessions. Patients may say, okay, if I touch the doorknob, I may get sick, I may get a germ, I may spread it, we may all die. Or sometimes it's just the feeling, if I touch that doorknob, my hand gets sticky and it's so yucky, so disgusting, and I may not be able to feel better, like non-sticky again. And then these contamination obsessions are coupled with cleaning compulsions. So often folks with contamination obsessions have these excessive cleaning, washing rituals. Another common theme is responsibility for harm, what we call harm obsessions. So in this one, patients are very much worried about causing harm. So if a teenager driving a car, if I'm driving, what if I'm not careful, if I hit someone? Or kid holding a knife, helping mom cutting, bread or something. Oh, I cannot touch knife, mom. I can't do it. If I hold a knife, what if I step our dog? What if I step someone? It comes up a lot in COVID. We saw so many COVID-related obsessions. It could be also contamination-based, but if I get COVID and I spread it and I'll kill somebody and I'll be ultimately responsible for that. And then this harm OCD often coupled with checking or reassurance seeking type of compulsion. So for a kid who's worried about stabbing the dog and cannot touch the knife, may repeatedly ask mother, mom, am I going to hurt my dog? Am I going to hurt my dog? Tell me I'm not going to hurt my dog. Or completely avoiding, using any utensils or knives. Another common theme is intrusive thoughts regarding sex, religion, or violence. Like thoughts such as like, am I a pedophile? And again, like kind of connected to harm OCD, am I going to hurt kids? And often these are coupled with mental rituals, some of the neutralizing compulsions. And then another common theme we see is orderly and symmetry type obsessions. It could be like compulsions could be organizing, rearranging, and sometimes we also see these just right OCD kids. Like the kid might feel like my body doesn't feel right if it's not symmetrical, or if when I'm walking, the steps has to be in orderly or kind of paired one another, and then they may just stop, they may not walk, they may just wait for this right moment to feel right in order to walk. So you can see this really compulsions impacting the kid's ability to move and, kind of look like a movement disorders or even catatonia. So let's talk a little bit about pediatric OCD. So often the prevalence is 1 to 2%. We see this peak twice. You see a pre-adolescent peak and then late teen or early adulthood peak. Much larger genetic loading in pediatric OCD compared to adult OCD. And it takes a long time from initial symptoms into getting to treatment, especially medication treatment, like somewhere between 7 to 8 years. When we get the history from like families, often, the description is like this anxious kid with anxious temperament, kind of doing okay, and then kind of having these odd behaviors or rules or routines, and then kind of ignored or not paid attention. This is more of a quiet illness, like the kids hide these things for a long time until to the point that they cannot function, they cannot give in the homework because they're so afraid of, making a mistake, or they're spending hours and hours in the bathroom, and at that point, parents are sort of aware that something is happening, and then this becomes a clinical question. And then even then, the range is 7 to 8 years to get to the medication treatment. One other point to make in pediatric OCD is not every pediatric OCD case progresses to adulthood. So we really think about in terms of treatment taper, when kids are doing well and stabilize after a year or so, we think about treatment taper in pediatric OCD, which is a bit different than adult OCD. This is Yale Child Brown Obsessive Compulsive Scale Child version, the checklist. So this is one of the tools we use in terms of assessment. This is a symptom checklist. So we go through this symptom checklist with the kids and then the parents. And then I have a different one, which I didn't put in here. We also have a measurement one that we ask about severity and rate, like 1 to 4, like 0 to 3, like how severe it is, how much the kid can resist compulsions, how much they interfere. So we also kind of measure. But the checklist is super helpful to kind of see how pervasive OCD is, because sometimes the kid can present with, like something much more obvious, like the hand washing is sometimes hard to ignore if the kid is stuck in the bathroom for 4 or 5 hours. And then when you do the checklist, you see how many other obsessions are in there that's sort of hidden and not very visible to others. Pandas, I wanted to touch base on pandas because I'm sure you guys kind of see this in pediatric world a lot. I want to say that it's rare in the world of OCD. It's such a small number. Pandas is pediatric autoimmune or psychiatric disorder associated with strep infections, or kind of lately more broadened with the PANS, like other infections as well. And it is, OCD is part of it. It's sort of significant obsession compulsions, usually also tics. And it's often has a abrupt onset, like overnight, like one day we woke up and this happened, and then has a relapsing and remitting course. Often it's a prepubertal onset, and it has a neuropsychiatric picture. So it's not just your straightforward OCD, but there are changes in handwriting, bedwetting, acute disordered eating. And the way I kind of see it is OCD plus a neurological picture in the context of an infection that happens abruptly and often in a pre-adolescent kid. And sometimes there's a wish on the family end to see things through medical lens rather than psychiatric lens due to stigma in psychiatry. So, a lot of times what we tell the kids we work with is like, it's not PANDAS, it's OCD, and we can still treat this. And even if it's PANDAS, the OCD component of PANDAS needs OCD treatment. If there's an infection, of course, we recommend go ahead and treat that infection. But when it comes to OCD symptoms of PANDAS, often they need our straightforward OCD treatment. There are some other treatment agents over there, you know, like IVIG or some other treatment options, which are kind of data is mixed. I mean, I didn't want to go into that in this talk. Could be appropriate for some patients, but again, I want to point out the OCD symptom cluster that comes with PANDAS still need OCD, our traditional OCD treatment with SSRIs and exposure therapy. A little bit on comorbidities and differentials. So tic disorders are very commonly seen. 20 to 30% per literature. I think in our residential unit, we see a very high comorbid tics. And then there is OCD plus tics. We are quick to augment OCD with antipsychotic medication because the evidence really shows us that comorbid tic with OCD, antipsychotic augmentation response rate is really high. Like these kids tend to respond to antipsychotic augmentation much faster than kids without tics. So I think about antipsychotic augmentation sooner on those cases. Other anxiety disorders are quite common: social anxiety, specific phobias, separation anxiety, especially with the younger ones. And our approach to treatment of other anxiety disorder kind of similar, like SSRIs and exposure therapy. ADHD is another one. Either it is like a primary ADHD or ADHD-like symptoms in context of OCD. Sometimes it's hard to tease this out, but literature, according to literature, somewhere between, I mean, depends on the study you look, but 20, 30% to 50% of kids with OCD, especially more severe, moderate to severe OCD, report ADHD symptoms. Our decision to treat ADHD really based on how impairing it is, and in our unit at least, like when we work with moderate to severe OCD patients. And if ADHD symptoms are so impairing that it interferes with the learning of exposure therapy, then we go ahead and treat. I mean, I'm in favor of treating ADHD when we see ADHD. Things to watch for when you treat ADHD in an OCD kid is the anxiety worsening with the stimulants. And often if there is some SSRI and some OCD treatment in there, the kid's ability to tolerate stimulant is much better. And sometimes we see that when ADHD is treated, the kid's ability to engage in OCD therapy is much, much better. Another common comorbidity is mood disorders, especially depression. I mean, we see it in our unit a lot, given the severity of the population we work with. And it's often like a complication of OCD that we see. Another one is autism. I think this question comes up a lot. Is it autism? Is it OCD? Is it both? The true comorbidity exists. It's not that common. I think in our residential program, we see a higher rates of ASD-OCD combination because of the, just challenges with outpatient treatment in this population. There's both comorbidity, but also important to think this in a differential because it's not uncommon. Even kids refer to us. Sometimes autism is misinterpreted as OCD. The stereotypies, some of the repetitive behaviors kids on the spectrum have for self-soothing can be misdiagnosed as OCD. So we often help patients and families to kind of differentiate the two. And finally, the psychosis spectrum is comes up a lot in our unit, given the severity of the population we work with. So psychotic disorders are very different than OCD, often emerges in late adolescence into young adulthood. And sometimes when the OCD is very severe to the point that patients cannot appreciate the irrational nature of OCD thoughts, it can be, the question of psychosis can come up. I think there's a sort of general understanding is that a patient with OCD would know that the thoughts are irrational, which is a lot of times is true, but not so much in pediatrics because children may not know the OCD thoughts are irrational, or sometimes when the OCD thoughts are very severe, patients can lose insight. They may not appreciate the the perceived danger of OCD is not a real danger. So at that point, the question becomes, is it delusional? And there's a whole category of OCD with poor insight and delusion, which is really different than psychotic disorders. But I mean, if the question comes up, I think a referral to psychiatry makes sense to make the distinction. And when we see a lot of OCD, and if we see that delusional beliefs are very much in line with OCD, then we kind of see that presentation as OCD and we try to treat OCD and see what happens. And then often these cases need ongoing monitoring to see if things evolve over time. I mean, the patients with OCD have a higher rates of psychotic illness compared to general population, but majority of people with OCD, severe OCD, do not develop psychosis. So I think longitudinal assessment is really the key for these cases where we kind of wonder about, is this OCD with delusion or if it's emerging psychosis. I do want to talk a little bit about OCD cycle and then we will jump to treatment. So OCD is like a loop. It starts with obsessions. If I touch the doorknob, I may get sick. That can create a lot of anxiety and distress. And then patient does a compulsion, go wash your hand. And then compulsion temporarily releases that anxiety, that lowers the anxiety. But it kind of feeds into the cycle. So the more a patient does compulsions to undo the obsessional anxiety, the more obsessional they become. So it becomes this huge cycle and feeds into each other. And then the more they do these compulsions, the bigger obsessions get. And then when we think about treatment, what we do is exposure and response prevention. This is the therapy component. And what I mean by exposure is that, when you're afraid of something, right, you want to avoid it as a human nature. If the patient feels like, if I touch the doorknob, I'm going to get sick, they don't want to touch the doorknob. They cover their hand or they ask someone else to open the door for them. And what we call avoidance. And as part of the treatment with child consent, of course, we sort of, after psychoeducation and having a clear agreement of that's the plan, we start exposing the patient to the feared stimuli, and then which would increase anxiety. And then the response prevention component is that not doing compulsions or changing or reducing compulsion. So we really try to intervene at this cycle. A little bit opening up on the ERP component. So exposure is exposing patient to the stimuli that creates obsessional fears, allowing themselves and not avoiding these intrusive experiences, intrusive thoughts. And then response prevention is interfering at the compulsion level, where we ask patients to either resist if they cannot resist, delay, or change the way they ritualize. And then once we start interfering with that cycle, often the obsessions and compulsions, it can increase, like anxiety will increase when they start doing ERPs, but eventually it really decreases obsessions and compulsions. The family work is huge. If you really, really closely work with families, it's very important in this type of work to support parents so they can support the kids in treatment. And families, like not wantingly, but they may make the OCD worse by accommodating. And what we call accommodation is the things families do to make the kid feel better, which will ultimately increase obsessions. And obviously for a mom and dad, right? Like if you see your child really struggling, crying, I give the example of opening the door, cannot open the door, crying in front of the door, or is stuck in the bathroom washing hands, or if they don't have access to soap and water, crying, sobbing, dysregulated. I mean, as a parent, you would want to make your kid feel better. You want, like often parents wash, open the door for them or give them soap and buy them more and more soap and giving access to giving one of the bathrooms to the kids so they can wash themselves as much as they can. So these things are done to help the child, often makes the OCD worse. So we really work with the families to teach them how this kind of accommodation makes the OCD worse and how to reduce these accommodations. Often like how to not participate in compulsions, because the patients with OCD can ask family members to be part of their compulsions cleaning, not doing tasks for them, so not helping kids to avoid things that they're afraid of. not changing family life so much to give more space for OCD, because the more we change things, taking time off or canceling family plans, or, you know, like we have families where the child's OCD takes over an entire household, where, you know, family members cannot go into certain parts of the house, or they cannot use the dining room. So you kind of see the entire family routine has changed. Or reassurance is another one, you know, mom, am I going to be okay? Am I going to be okay? And then, of course, as a parent, mom would say, yes, you'll be okay. You're fine. But then it's reassurance seeking. And then we teach parents how to not give that kind of reassurance, instead having kids like responding by like asking, this is your OCD, asking, you know, the answer to this. So kind of really changing the way families interact with OCD. So the OCD doesn't take over the child's life. So, I think we can talk a little bit about medication treatment. Most of our knowledge comes from POTS study. Our initial knowledge from back in days from 2004. So POTS is a multi-site randomized controlled trial for pediatric OCD treatment. And they had 4 arms. They had CBT alone, CBT with an SSRI combined. And in this study, the SSRI they chose was sertraline, SSRI alone, and then the placebo. And then they looked at how kids do. And what they found is combined treatment, CBT plus, and I want to clarify, like when I say CBT here, it's exposure and response prevention. Like ERP is a form of CBT, but for OCD treatment, we really want CBT to be an exposure and response prevention type CBT. So when they look at responses, so combined treatment with CBT with an SSRI worked much better than medication alone or ERP alone. And similar remission rates combined was much better than CBT or medication alone. And obviously placebo was like the worst. And the medication definitely worked better than the placebo. So there's kind of indisputable, like medications work. And our take-home point from the study was that combined treatment works best. For pediatric OCD, if it's mild cases, it is reasonable to start with exposure therapy as initial and see if the child makes progress with ERP alone. But if it is kind of impairing, moderate to severe, or there's an urgency to get the kid stabilized faster, then starting combined treatment makes sense with CBT and SSRI. And then in terms of medication, like SSRIs are really the first line medications, and I will talk a little bit more about that. Okay. So, I mean, I would say any SSRI would work. For kids, often we use, and if they're approved, like sertraline, fluvoxamine, or fluoxetine are first go-to, but I've definitely used other agents like Lexapro or some other SSRIs as well. The key with anxiety and OCD is we want to start low and go slow with anxious kids and families. And then we gradually increase doses 1 to 2 weeks in the outpatient model to the target dose. And then you monitor weekly for tolerability. And some of the side effects are, you know, you just monitor, and if they come up, you lower the dose or wait or kind of delay dose increase, such as GI side effects are so common, like feeling upset stomach and nausea because we have so much serotonin in the gut, or headaches, or like these things tend to kind of clear up like quickly. And then sometimes kids can report a little bit disruption in sleep, a little bit restlessness, some mild anxiety. You kind of watch for these things to see if they get worse or kind of settle down. And when we think about activation, agitation, or severe irritability, then we worry about it. So, which is rare and often seen at much higher doses, or sometimes in young children, they may not tolerate. So these activation, agitation, and severe irritability is a reason to hold the treatment and then consider a psychiatric consultation. Similarly, suicidality is another one. I mean, there's a whole black box warning that came out many years ago, and that unfortunately decreased SSRI prescribing in primary care, which kind of correlated with increased suicidality and depression in kids. But it's rare, but if we're hearing about, you know, in the context of starting SSRIs, if we're hearing about suicidality, brand new suicidality, that it could be an indication to, assess for safety, of course, if a higher level of treatment is needed, but then involving crisis team, consulting with MCPAP, involving psychiatry at that point is really important. Any questions about this?
Hey, Esra, I'm going to just jump in for a moment just to kind of call people's attention to the fact that we have an OCD clinical algorithm that's available on the MCPAP website, and everything that has been said, today, as far as the particular choices of medications and the titration strategies and things like that are covered in the algorithm. So that's kind of a handy sort of thing that you can sort of look at a glance, and it particularly recommends the same, medications, sertraline, fluvoxamine, fluoxetine, with guidelines for dosing. I guess the only difference that I would point out is that that you had recommended increasing or titration of doses every 1 to 2 weeks, which is something that, obviously it's a matter of clinical style, sometimes, but our algorithm had recommended 4-week intervals, for monitoring. I think it's just in some ways it's a stylistic difference, but just to know that you might see that discrepancy if you compare these slides with the algorithm.
Yeah, I mean, I think the frequency of dosing is really context dependent, child family dependent on the clinician's comfort level. I mean, in our residential unit, we even titrate faster than this. In an outpatient and pediatric setting, I can imagine things has to go a bit slower. So yeah, I think it makes sense to go with what feels more comfortable and right for that context. So I pulled this. This is from ACAP practice parameters, a little old, but useful, just to give you guys a bit of a dosing range on medications. We mentioned fluoxetine, sertraline, fluvoxamine. The paroxetine we don't use in pediatrics, and then Stelopram, like sometimes I use Lexapro rather than Celexa. And then the clomipramine is another one, which is not a first-line treatment, but we often consider clomipramine for patients who failed 2 SSRI trials, and there could be a consideration for, again, psychiatry referral, but it could be a very effective. It's a TCA, it's not an SSRI, and it needs certain monitoring, baseline EKGs, and at a certain levels you need to monitor levels and stuff, and I may actually have a slide on that. But not the first-line treatment, but we think about clomipramine OCD treatment. Any questions about that?
Yeah, so far no questions in the chat yet.
All right, so how long do we treat? Comes up a lot. Once we start a medication, do we have to stay on the medication forever and ever? And I often tell patients and families is no, like not everyone has to stay on medication, but there's not a one response, like one answer to this. For some patients, they can come off of medication and do well. Some people, they may relapse and they may want to stay on medicine so the symptoms don't come back. From a data standpoint, most of our knowledge comes from adult studies, recommend at least 1 year of treatment, like 1 year of stability after successful treatment. And then once you start tapering, it has to be very gradual, and because relapse is so common. And if you taper before 1 year, the relapse rates are much higher versus after 1 year. And then for folks who have relapses, repeated relapses, then we usually recommend maintenance treatment to stay on medication. And again, when it comes to pediatric OCD, we do recommend medication taper after, I usually say after a year of stability. And when we say taper, it's not like you stop treatment, like you start pulling down on the dosing. Say a kid is on 250 of sertraline, and then doing really well for a year or 2, and then we start gently coming down on the dose, and then see how the kid does. And if everything is good, then you again slowly come down on the dose, and then kind of monitor the symptoms. And if you see emerging, like the slow taper is really helpful. Like if emerging symptoms kind of start poking its head, then that's a sign. Okay, kind of pause here, maybe go up a little bit and stay there. Maybe the kid doesn't need 250 of sertraline, but then maybe they need 150 for maintenance. So you really find that middle ground as you come down on dosing. And again, go slow and gentle, and then monitor for emerging symptoms. Okay, the other question is, what if SSRIs are not enough, which is the world I live in, because most of our patients are on SSRIs and then they don't do well and come to our residential program. So I think it's important to kind of remember that even if someone responds to treatment, which I think defined as somewhere between 25 to 35% reduction in symptoms, if your starting point is really high symptom burden, even if you respond to SSRIs, it may not be enough, and you may still have significant functional impairment. And then we think about, augmentation or dose escalation and other strategies. 1/3 of patients don't respond to first-line treatment. So if you fail one SSRI, and when I say fail, I mean good dosing. I mean like decent dosing in a good time. So we're not talking about treatment intolerance. We're talking about treatment failure. Treatment intolerance is, discontinuation due to side effects, anxiety, some other things, and we don't call it as a failed trial. But if the patient doesn't respond to one SSRI, we usually do a second SSRI, and if a patient fails two SSRIs, then we may consider clomipramine at that time. Before we call something didn't work, we want to see dose escalation if tolerated. This is kind of modest but significant advantage to use high dose SSRIs in OCD treatment. Then the pediatric studies are lacking in this. I think it's more of a tolerability issue. Like little kids don't, like younger patients don't tolerate high dose SSRIs, they get activated. But in late teens, teenagers, late teens, and adults tend to do much better in high dose SSRIs. So I think it's a reasonable thing to consider to increase SSRI dosing if tolerated for better OCD response. Clomipramine is another agent, again, not our first line due to side effect profile. We can use clomipramine either as a primary agent if someone failed two SSRI trials, or sometimes we use it as an augmentation strategy. But then we combine clomipramine SSRIs. We're also really mindful of the interaction because, Prozac, Luvox particularly can interact and really increase clomipramine levels. So that is something I think important to get psychiatry input on. For clomipramine treatment, as a primary agent, we always get a baseline EKG, and then initial target is 1 mg per kilo, and it can go as high as 3 mg per kilo. I monitor levels and not to combine levels not to exceed 500, and then at the high levels there's a risk of cardiac arrhythmias and seizure. And then another common strategy for augmentation is antipsychotic augmentation. And again, as I mentioned before, the comorbid tics tend to do really well in this category, and about 1/3 of patients with treatment-refractory OCD that didn't respond to SSRI treatment do well with antipsychotic augmentation. And I go with aripiprazole due to side effect profile. It is sort of easier to tolerate among many other antipsychotics because we worry about metabolic side effects with antipsychotic medications a lot. And often antipsychotic augmentation is not like SSRI is more of a long-term strategy, versus we see as antipsychotic augmentation is a shorter-term strategy because we don't want to long-term exposure to antipsychotics in kids unless we absolutely have to. And then avoiding medications like olanzapine, which has significant metabolic side effects, is kind of reasonable. I mean, obviously there are cases where we have to use olanzapine or some of the heavier agents if needed, but our first choice is really be mindful about metabolic side effects of antipsychotics. And the last one I have on the list is TMS, transmagnetic stimulation, which is like a UV ray coil in your head. It's non-invasive. It is transmagnetic stimulation. It doesn't hurt. It's mostly used in late teens, not with the little ones. And McLean has a TMS suite. Sometimes we refer kids for TMS. There's a specific coil they use for OCD treatment, and there's upcoming evidence for that.
Hey, Esra.
Yes.
Oh, you might be actually addressing this in the next slide, but I was going to ask you to speak to sort of this concept of what the appropriate target, for an initial medication trial, should be. We talk with primary care providers, quite a bit about sort of this notion of treatment to target.
Mm-hmm.
And then medication adjustment, titration, all that kind of stuff, and modifications and psychotherapy and other treatment plans, are related to, just the challenges of getting people to whatever that target is.
Mm-hmm.
And in our experience, and I'm sure that it's not just ours, that OCD is a chronic condition, and that oftentimes it's really not appropriate to expect the medications to pretty much bring people into remission, in the way that we think of it for depression. For example, our target for depression is remission. Our target for OCD might not be remission, because that might be unrealistic. And then the issue has to do with people ending up being over medicated if you have sort of an inappropriate target. If you expect the medicines to induce a remission, then you might be more likely to be prescribing antipsychotics. You might be more likely to be using higher doses than necessary. And so I wonder if you can speak to that issue, because I think it's a common question that we get as far as what to do next, when you have residual symptom burden. Yeah.
So yeah, I think it's really important to kind of point out what is the goal of OCD treatment, and how we define even remission. Because the idea is not that you won't get intrusive thoughts. Like if like the way we kind of teach kids is like your brain is like tend to have all sort of thoughts, and some of these thoughts are sticky, some of these thoughts kind of disturbing or come up a lot, and then what we teach kids is like, really, you need to observe your thoughts as thoughts and try not to change them or stop them or engage with them, just observe them. So I think the same mindset also applies to treatment. So our goal is not to make the thoughts completely go away, because it may not. Our focus is functional recovery. We want these kids to be able to function in the world, to be able to go to school, eat regular meals, be able to sleep in the bed, not spend 5 hours in the bathroom. So these are the criteria we look at, and we don't necessarily view treatment responses not having intrusive thoughts at all. Like, that's not realistic. But then realistically, an OCD kid can really improve and be able to not engage with these thoughts as much and not pay attention to these thoughts as much. These thoughts intensity, how loud they get, how much power they have on the kid can decrease. And the medications, I mean, I think it's also true for depression treatment. Like, the medications have definitely a role. Like, a lot of these kids can't access to therapy without medication support when the symptoms are so impairing. But then a lot of work also goes into therapy. So for OCD kids, they have to start opening that door, or they have to start resisting the urge to wash the hands in order to get better. Without that work, without that exposure work, the medication itself is not sufficient for improvement, like full improvement. And in terms of like what to target, what dose to target, I think it's really kind of following the functionality algorithm. I think, like, how does OCD impair this kid's life? What are the treatment goals? And what do we want to see as improvement? Like, if a kid is unable to go to school due to, I don't know, not being able to use the bathroom at school, then okay, let's work towards that. And then I think it's also important, a bit different than a medication treatment of a kind of strep throat I just had and got better with antibiotics. Like, this is not a condition that's going to get better with just SSRI. So, onboarding an exposure therapist, working closely with the ERP therapist is really key in OCD treatment. And then to pull on psychotics or when to really high dose SSRIs, I think these questions for pediatricians, at least, I think this could be a reason to have a psychiatric consultation and kind of make the decision making. I think there is definitely a role for high dose SSRIs around psychotic treatment and OCD treatment, but then majority of the kids won't need it in the community. And And again, we don't want to treat this to make the thoughts completely go away. Our focus is functional recovery and the kids to have a life where they can, live their life without OCD really taking over the whole, like, everyday.
Yes. Great point. There's, I'm glad you brought up the issue about the interaction between the medication and the psychotherapy. That, I think you implied this, and if not said it directly, but I actually feel that sometimes if you're too aggressive, with wanting the medications to really, kind of extinguish all the symptoms of OCD, then you could potentially undermine the psychotherapy, because the psychotherapy does require, something to work with, that there's skill development, there's desensitization, that has to happen in that kind of ERP psychotherapy that does require some ongoing symptom burden. And so that could sort of also influence the sequencing of the treatments, where you might, if you're doing combined treatment, you might start the psychotherapy right away, because there's a long, relatively long wait, before the medications work. And that way you can really take advantage of the fact that the symptoms are active, for the psychotherapy. So that's an interesting point.
I mean, the way we think about, I think about medication is that, the symptoms are like this high, so severe that the kid cannot really pay attention or engage in the exposure treatment because they're so anxious or so overwhelmed or so impaired. So the medication tunes down the intensity of symptoms a little bit. So it kind of gives more room for treatment therapy to work. And then the kid engages in therapy to make these behavioral changes and then start doing things that they've been avoiding for so long. But then we never expect medicine to make the whole thing go away, because it's not, you can't really just medicate some of these avoidant behaviors. Like, the kid need to relearn, and the ERP work is all about learning. So the kid need to learn. At some point they learn, if I touch the doorknob, I'm going to get sick. So it's some sort of learned behavior. And then the exposure therapy really teaches them, it kind of teaches something else. Like, we're going to teach you that when you touch that doorknob, you're not going to get sick. So let's try this new thing and have your brain learn this new thing. So the kid has to learn this new way of, or like old way of being, and the medication won't be able to provide that. That has to come from exposure therapy. Okay. Moving on to a little bit more on the refractory cases, and this is a powerful little bit assessment and our approach for kids who don't do well, like, kid who's on a Prozac and still struggling, or or tried a couple of medications and still struggling. Often the typical patients that refer to my program. So the way we kind of define treatment refractory is patients who failed 2 full SSRI trials or 1 SSRI and clomipramide, and not or, and failure to adequately delivered CBT with like with ERP component. And then we ask these questions: is the diagnosis correct? Because sometimes OCD can be misdiagnosed. Like, could be a primary depression with ruminations, could be like a primary eating disorder, and disordered eating may not be related to OCD, or could be like emerging psychosis and not OCD. Or like it's an AST and not OCD. So we kind of like go back to diagnostic and really try to understand if it's truly OCD or not. And then the second question we ask if the first-line treatments are properly provided, optimally provided. Because when it comes to SSRI trials, there's a conversation about, I think I mentioned a little bit ago, failed treatment versus treatment intolerant. Because we want medications to be properly dosed and at least 8 weeks at the maximum tolerated dose. And then the max dose is more like a max tolerated dose. Like, we don't necessarily target like sertraline 250 on a child. Like, maybe that kid can only tolerate sertraline 100. So it's important to kind of know each patient's tolerated max can be different. And kind of make sure that we reach that maximum tolerated dose if they're not doing well, if they're still impaired, and not stay on that dose for at least 8 weeks before calling that treatment didn't work. And compliance is always an issue. We always assume that people take their medication, and often they don't. When it comes to therapy, we assess if the CBT or therapy is exposure therapy, exposure and response prevention. And then we assess for comorbidity. So sometimes comorbid conditions interfere with OCD treatment. So we treat those comorbidities such as depression or comorbid ADHD. We assess the level of insight. For insight, kids tend to engage less. We assess and intervene at the parental accommodation and an overall engagement and compliance with treatment. And finally, medication conversation. So I think it is sort of important to think about what medications can and cannot do. I think earlier we were talking a little bit about this, but medications are not cure-all for a lot of psychiatric disorders. And we need to sort of have that conversation with the families and with ourselves, with the kids. Like medications are one of the tools in the toolbox, a very important tool in the toolbox. And their purpose is to lower the symptom burden so the kid can engage more in exposure and response prevention treatment. And our goal with the medication treatment is finding this therapeutic window with good clinical response and acceptable level of side effects. Not necessarily no side effects, but acceptable tolerated dose, acceptable level of side effects. And I feel like evidence-based treatment is our friend. I often share what the literature is with the families so they can make a good informed decision. I often discuss risk of not treating. Sometimes with anxious kids and anxious families, decision about medication can be really hard. They may worry a lot about side effects, which I understand. But then when we talk about risk of side effects, I think risk of not treating a condition is part of it. And then monitoring is really the key. Like if it is a team effort, being very open and mindful and kind of responsive. And when I say team effort in our unit, we work closely with patient families, pediatricians, psychiatry, nursing. Like the team effort really the key for a successful medication trial. I have.
Barry, you're on mute.
Well, thank you so very much, Beth, for telling me I was talking. But I just wanted to thank our presenter for a really nice overview of this topic, really the assessment and treatment of OCD. And we do have one question so far, and I have a couple of questions, and we'll see if we get some more. But we have another few minutes to discuss. And so the one question we have from a person by the name of Maggie is just if you could speak to the nature of OCD, as organic brain-based condition versus something that's rooted in psychological conflict.
Good question. I think the way we think of psychiatry is a brain-based thing is also rooted in psychological stuff. So it's sort of a biology and environment interaction. And then environment doesn't always have to be the trauma. So for OCD, for example, it's a very biological illness. Like there's certain parts of brain reacts in a certain way and responds to serotonergic-based treatment. And then what happens in interaction with the environment is that OCD, like the example I gave is like the kid cannot open the doors and ask family members to open the door for him, or the kid has these extensive cleaning rituals and then ask every family member to wash their hands or change their clothes at these extensive cleaning, ask family members to do these extensive cleaning rituals with them. And the more families engage with these rituals with the child, the OCD gets bigger and bigger. So there's a biology, but there's an environment, and the combination of biology and environment makes the illness progress or get better. So that is how we see it. But it's a very biologically oriented disorder. But I feel like a lot of, everything in some ways is biologically oriented. Even like the most even a very psychosis, we always see very biologically oriented thing. But the expression of psychosis and the outcomes and treatment of psychotic disorders is very much depends on the environment and psychological factors and how much therapy the patient receives, and it's very much intertwined.
Thank you so much. It's as you said, just I'll add to that to say that everything in psychiatry is both. That there's biology, there is psychology, there's social. That's sort of the interaction with the environment and the so-called ecological system that all children live in. I guess one thing that we can say, I think with reasonable kind of authority, is that there is an antiquated view that OCD is caused by psychological conflict, particularly unconscious conflict. That one of Freud's earliest cases is a patient he described as referred to as the rat man, and that study that he wrote up really posited a unconscious conflict sort of basis for OCD, but that really is not the contemporary view, and oftentimes I think we do see patients who have unconscious conflict that are driving obsessive compulsive symptoms. However, these are usually not patients that meet criteria for obsessive compulsive disorder. They're probably more likely to meet criteria for obsessive compulsive personality disorder, which is a different thing, than OCD, and might sort of be appropriately, addressed, with more of an insight-oriented psychodynamic psychotherapy. But the psychological piece, for OCD, that in terms of the contemporary understanding, is more based on the interaction of biology and environment, and the way that symptoms can be reinforced, in the vicious cycle that we heard about in our presentation today. So that's just clarification.
Right. I think it's really important to think about this, like our biopsychosocial formulation, like you mentioned. And yes, I mean, underlying psychological disturbances or conflicts can worsen an existing thing. It could be OCD, it could be depression, it could be schizophrenia, it could be anything. It could be asthma, like it could be a very medical condition. So these things are interact with one another, but OCD is not caused by a conflict with another person. OCD is a biological disorder, can be worsened by conflicts or other environmental factors or psychological factors.
Thank you. So there are no other questions. I'll ask one more. We have time for. So you talked about the insight issue, and how common it is for children not to have insight. And just for the audience, when children don't have insight into an anxiety symptoms, they usually kind of see the problem as being, what they're afraid of, as opposed to the fact that they're afraid of something. So if they're afraid to not, do a certain ritual, they see that as kind of an objective, danger, and if you try to work with them to, sort of not, respond to this urge to do this ritual, in an ERP framework, then they're going to see you as an adversary. They're going to think that you're, a threat, because you're telling them, you're trying to help them and to do something that they consider to be dangerous, kind of, and that's just a general, sort of statement. And so that question is really, how do you work with, kids who really don't, buy into the idea that their OCD is a condition that needs to be treated, as opposed to, they need help to do their rituals, and they need kind of, people to accommodate, all their anxieties and compulsions.
Yeah, I mean, great question. And I mean, I jumped into exposure therapy work, but, our first go-to in ERP work is psychoeducation. Like, we don't start with doing exposure. We start with teaching the kids about OCD, like how OCD operates, how common it is. We have kids write their OCD stories. We have kids listen to each other's or other kids' OCD stories. So a lot goes into this, building a psychoeducation framework and understanding before starting exposure therapy. So you can't just expect a kid to be able to not do the thing that make them feel a little bit better without understanding why we ask them to refrain from it. And how do we align? How do we find a way to work with the kids who can say that, okay, I understand this is my OCD, could be an OCD or may not, but I just don't want to do it. I am so terrified of touching that doorknob. I'm so terrified of not washing my hands. And then we talk about the values, like the way we engage with these kids is like, okay, this is really hard, and it seems like OCD really took over your life, but put the OCD aside. What kind of life do you imagine for yourself, especially with teenagers? Like, do you want kids to be able to see their OCD separate from themselves, like separating the illness from the person, and then bring the values of the person to the surface? Like, what would, Jenny, what would, John would like to do? What kind of life do you want to go to school? Do you want to be able to sleep in your own bed? So kind of almost like start to build and talk about, create this narrative of how life could be if OCD is not interfering. Then what are your values? What are your values as a person? What are your values towards school or life or eating? And then, because eating and drinking sometimes can be really impaired with OCD. And then once we find a mutual ground, mutual goal, then we build our treatment towards working towards that goal. And we can't do exposure work without the patient's willingness and engagement to do.
Wow, that was really good. Thank you so much. By the way, for the audience, Dr. Guvenek-Cokol is describing sort of what a psychotherapist, often does, with patients with OCD, with children. And obviously, you're not going to be doing, if you're a primary care provider, you're probably not going to have time to do ERP. But it's really good to know, the principles, that are underlying the work of the psychotherapy, because you could have an opportunity to reinforce, some of these ideas. When you're talking to kids about their therapy, you might ask them, so how's your therapy going? And they might sort of tell you, or the parents might tell you what the therapist is doing. And if you know and understand, some of the principles, you can sort of say, well, that's really very helpful. And you can kind of reinforce them, or you can, further kind of explain, sort of the rationale behind what's going on in the therapy. So I think that's good to know. But thank you so much again. This was a wonderful talk, Dr. Esra Guvenek-Cokol from McLean, and thanks everybody for attending. And we will look forward to seeing everyone in May for our suicide prevention algorithm, May 28th. And have a great rest of your day.
Thank you so much.
Bye.
Bye.